So we have been working for the past 5 years with this concept of metal-free approach. I started with Absorb, now I've used MERS100, sometimes drug-coated balloons. We really believe that this is a goal, but nevertheless is a goal that we need to pursue, because we don't want to be remembered by future generations as people paving vessels with metal. I have no conflict to disclose. So I think the most important advantage of bioresorbable scaffold is positive remodeling. And no technology, maybe with the exclusion of drug-coated balloon, can give you this. But when you see that the area goes from 8 to 10 after 5 years, you really understand and you take the advantage of this technology. Like any stent, BRS requires optimal lesion preparation. And this is not only for BRS, we forgot, even with meta stent, that optimal lesion preparation is essential. In our experience, no restriction the type of lesion if optimal lesion preparation is performed. We have implanted the bioresorbable scaffold even in calcific lesions, provided the preparation was optimal. We have rotablated, we have used a shock wave, and this is not to say that we have to start a trial with these lesions, but to tell you that if you prepare the lesion well, then you can go a step forward. Shockwave and rotablator for optimal BRS deployment in LED severe calcified lesion. We have recently used the MERS100 in 12 patients followed almost 2 years. These were complex patients. We have 1 CTO, 3 bifurcation, scaffold implanted per patient 1.7. We have used IBUS because our lesion selection was complex. The mean follow-up is 283 days. We have 1 death. 15 days after the index procedure, we have no information what happened, no other event, and 2 patients underwent CT with a good result. I show you 1 case as an example of what we did. You see the diffuse disease LAD, subtotally occluded on the right panel. The lesion is crossed, nothing special here. It's a long LAD, injection distally to make sure you are in the right lumen. I go quickly here because this is just routine. Is well pre-dilated using non-compliant balloon, cutting balloon, and then we implanted a meta stent proximally. Then we do high pressure, bioresorbable scaffold proximally, high pressure dilatation, and you see the distal with balloon only. Here another example, LAD, focal lesions, large vessels, large plaque burden, lesion preparation is recommended. 1 MERS long implanted, post dilatation, it should be done, and another implanted more distally. The IBUS shows optimal expansion. Then treatment of the intermediate branch, same fashion, pre-dilatation, In this case, we use drug-eluting balloon. We treated this tortuous intermediate first with drug-eluting balloon, but the result was not acceptable, and we implanted a scaffold. If you have incomplete expansion, you can use shock wave even after having implanted a bioresorbable scaffold. This is an LAD, nothing tremendous, but the balloon did not cross, so we had to use hot ablation. We did IVUS, which shows reasonable lesion dilatation. We implanted the MERS100, but after the MERS in this frame, the one on the left center, you see incomplete expansion. Then we did the shock wave inside the MERS with improvement, and you see in green the difference between the red. The red is before shock wave, the green is after shock wave. You see good symmetry. Here also in green, better symmetry, and here also as well with the lumen that go from 4.6 to 4.8. So here is the final angiogram. So you can do ablation with lithotripsy even after having implanted the stent. This is the combination of bioresorbable and drug-coated balloon, diffusely diseased LAD with tight lesion proximally and suboccluded vessel more distally. Usual pre-dilatation. I go fast here because this is standard angioplasty. In one area the balloon is not fully expanded, so we use lithotripsy. Then we use cutting balloon, non-compliant balloon, high pressure 20 atmosphere, cutting balloon more distally, then optimal lesion preparation. So even if it's calcific but you reach optimal lesion preparation, we go ahead with MERS implantation proximally, diffuse disease distally. We can implant bioresorbable, but the vessel is relatively small, so we do an attempt to do optimal PTCA. We measure the gradient with a pressure wire. The gradient is significant. You see PDPA 84, contrast FFR 0.77. You cannot leave this lesion distally. We do a better lesion preparation with a semi-compliant balloon. Then we use DCB, and the distal, despite some linear dissection, the flow is very good, and we double check the result by pressure gradient. The angiographic result is excellent. You can leave it like this, but we want to be sure. We measure the pressure gradient that is now 94, so very acceptable. Distally is 91, and the contrast FFR 87. So this is what we call hybrid approach, bioresorbable scaffold proximally and drug-eluting balloon more distally. This is the final result. There is a dissection, but this is a benign dissection, and this is a long diffuse disease LAD treated with no metal. So I like to call this metal-free approach. So the lesion is optimally pre-dilated with a goal to reach a good angiographic result. If you have a bad dissection, you go immediately with a bioresorbable scaffold implantation. If you have an optimal result with or without dissection, we encourage to do pressure gradient measurement. If the pressure gradient is low, we go with a drug-coated balloon, maybe with focal BRS, where the result is suboptimal. if you have a high pressure gradient or you are not happy angiographically about the result, we go for BRS. This is the early approach. We are not ready to use this metal-free approach in a randomized study, but advanced operators with skills in lesion and patient selection should move our field forward and try to go one step further and try to go into a new era where metal is slowly taken away from our coronary artery.